Thanks for those inputs, Katleko and Faith. I'm glad to see you doing so well, Faith, and it's been a while since we last chatted. Yeah. So hope all is going well in the UAE for you. So my topic is on personality disorders and impacts on substance use, and we'll keep it wide in general. And if there's any questions whatsoever, feel free to share, and we'll discuss them. So I don't want to say that there's any specific type of personality disorder that utilizes substances. People will use substances in all types of situations. Doesn't mean you have to have a personality disorder to be using substances, but yes, there is a comorbidity between substance use and personality disorders. And we can use substances for various reasons. We can use it because we are depressed. We can use it because we are avoidant, and it allows us to enter into social situations. Even people who are so-called antisocial, they'll say that up to 80% of people in prisons are antisocial. And there again, to deal with the fact that they may be going through some level of maybe hopefully guilt, remorse, they will use substances to numb those effects. So yes, with personality disorders, there's a huge overplay into substance use. And just to go through some of them, you get what we call the suspicious personality disorders, the paranoid, the schizoid, the schizotypal. And there again, being in a paranoid state, we all might experience at some level being paranoid. In South Africa, we experience it at various levels. You have to be a bit paranoid sometimes. When you pull up to a traffic light in the middle of the night and there's someone walking up to your car, so you will feel anxious and stressed. Some of us then will utilize substances to numb that anxiety and stress, to deal with that whole situation. That's not necessarily a good coping mechanism. Then the other ones, which are called the emotional and impulsive type, which are the more antisocial, borderline, histrionic, and narcissistic personality traits. And these have a strong element of ego in them compared to the others. Then you get the anxious personality types, which are more the avoidant, dependent, and obsessive compulsive. And again, yeah, we will still use substances because we find that by the anxiety that we have is addressed by the substances. And one of the things Gibson asked me to chat about is when we refer patients. And one of the things when we find we refer patients, you get the personality types, yes, they will come into rehab, but a very more important thing to look at when patients are being referred to the facility is to make sure, exclude, there's not necessarily an untreated psychiatric disorder, and more importantly, a medical disorder. Now be wary, when patients are intoxicated, we're covering up all the other symptoms that may be at play. We may find patients are delusional, psychotic, paranoid in that substance-induced state, be it due to marijuana or alcohol. And these can cover up underlying symptoms. So it's very important that they are assessed medically. And this is where people like Dr. Steve come in. And in fact, if you feel that they're fluctuating in terms of the usual presentation, it's very important that we be assessed. Because sometimes you can be the healthy young person using substances, but the problem is perchance in that state you fell over and hit your head. And as much as the patient is maybe intoxicated, maybe bleeding from the forehead a bit, one has to be careful that there's no underlying things like a skull fracture or something like that, which we won't know until the patient is well. And then too, when the patient is not intoxicated anymore, they may complain of headaches, and we sometimes are likely to dismiss it as a hangover or something to that extent, and we still have to be very diligent. One of the things I say about being a doctor in this profession is that it's the story of I think it's Peter and the wolf, or he would sit up at the top of the hill with the sheep all day and then would get bored. And eventually will shout wolf, wolf, and all the people from the village will run up the hill to come because there's wolves around. And Peter did that because he was bored, and he did it once, twice, 3 times. Eventually everyone gets bored with the fact that Peter's calling them and they say, he's lying. But the one person who has to run up because people's crying wolf is the doctor. Because it's the time when you don't run up is the biggest emergencies that happen. And that's where you have to make sure that the patient's fine regardless of the fact that this is the 3rd, the 4th, the 5th time that they're calling you for that headache. And yes, they've been examined. you have to go in with a clean slate and make sure that it has not progressed, that they've not fallen for the first time ever, and there's various other comorbidities that we face as a result. Patients will complain of chronic headaches, patients will complain of pain, and this is where it's important to still diligently examine and see what's going on with the patient. I'm not asking that we examine, but all of us in some ways are exposed to patients, and we sometimes very much want to brush off what the patient's saying because we find them, coming to our rooms all the time, or we might even use the word irritating us all the time. It's very important that we treat it as we would any other patient, as if we're seeing the patient for the first time. And yes, as a result of personality types, sometimes we will want to, if someone is antisocial, we'll find that we don't want to be in their presence. But then again, we'll need to examine and treat the patient as we would any other patient. So it's very important to exclude what we call the medical causes, and then also in the course of the patient's treatment, also constantly look out for psychiatric disorders. Now, one of the things we experience is that with substance use, patients can become, nowadays, the example I use with substances is that we're finding that the substances are becoming far more and more potent in their presentation. Patients will describe smoking 1 joint a week, but nowadays I think the potency of the substances is so much more. Again, another analogy I use is to describe how we drink coffee. And I think in South Africa 20, 30 years ago, when we first drank coffee, it was the instant coffee, what was called the re-coffee, the Frisco coffee, which is quite the brand name. Nowadays, no self-respecting restaurant will sell you that stuff, we hope not, in a good way. We want our coffee as potent and as lethal as possible in terms of its caffeine content. So what has happened over the years is that we don't settle for just a basic cup of coffee. We want our double espressos and those kind of things. And over time, as much as the coffee has progressed, the substance use has progressed to a level where the potency of, be it the marijuana, the alcohol that people take, is so much more. We're finding that patients are describing taking 1 joint per day or per week, and you're finding that the impact that it has on them is so much more. Interestingly, in the United States, where one of the things in South Africa that has been described in research papers, that there's a overlap between substance use and, for that matter, a psychiatric illness called schizophrenia. Now, for those of us who don't know schizophrenia is where you will present with delusions, paranoid delusions, auditory hallucinations, even what we'll call negative behavior, where you become disorganized, your speech will not make sense. Now, some of you might be thinking, that describes a person when they under the influence of substances. But what we're finding is that as much as you may be taking substances, there's a comorbidity. That means you are likely to also potentially develop illness like schizophrenia, which is, for example, where you feel paranoid. And that will be ongoing, regardless of the fact that you've given up the substances. And we say in the literature that there's a 1% chance that you will develop from a substance use to schizophrenia. Now, many a time we find that due to the potency of the substances that I spoke of, patients will now develop to a point where they are experiencing the psychosis and the delusions for a longer period of time. And this can last. We're finding patients experiencing the delusions, the paranoid delusions, the inappropriate behavior for weeks, for months. And they have to be on some level of antipsychotic to assist them, no matter how much, and this is very important, no matter how much we may speak to them, no matter how much we may endeavor to counsel them, this paranoia, the psychosis in this day and age can only be reversed with medication. And very, very specific medication. These will be things like antipsychotics. And the ones that we tend to use are ones like, I'm going to give you some brand names as such, risperidone, because these are some of the antipsychotics you'll find your patients on. olanzapine, which the brand name, one of the brand names is Zyprexa. There's newer ones now, Abilify, which has been around for a while as well, and a whole host of other antipsychotics. And when these patients are ill, it's very important, even if they've been taking substances, that these be treated. Because what is the other thing we've got to be careful of in assessing a patient? We have to do what we'll call a risk assessment. And there's 4 to 5 factors that we take into account in terms of risk. Probably the most important one is risk to oneself, because patients in that paranoid state may do something to themselves, like we've had a patient I'll describe in a facility that hid in the air vents of the air ducts of the involuntary facility. They couldn't find the patient, and they actually went searching around the area for the patient, and they found her eventually hiding in the air vents. So patients at risk to themselves, not just in terms of hiding, sometimes harming themselves because they feel that the voices are after them, and they feel they may need to jump off a building or something to that extent. The other consideration is risk to others. Patients in that psychotic, inappropriate state and their paranoia can view others as a threat to themselves. And this can very, very much be family as well, because these are the themes that we're going around, and this is the people we're surrounded by. So patients are a risk to themselves. The third risk is risk of absconsion, where patients in that state, and this is very important as well, because if you have a beautiful facility like, let's use Eden Tranquility, one has to be careful, because patients are more likely in that psychotic state to want to run away because they feel someone or other may be against them, even though that's not true. And they're more likely then to skip the wall, to wait for the gate to open and run out into the road. So these are the concerns that one has to have. The fourth one is risk of compliance. So we find as well that as much as the patient's adhering to the program, you're giving the medication, the patient's not improving at all. The doctor's upping the meds and there's no improvement. And we find that the patient, again, in their paranoid state, is less likely sometimes to take the medication that's given. They'll hide it in the mouth. They'll spit it out at occasions where they feel no one's looking. In fact, they've done studies in psychiatry facilities on the ground outside the windows of the particular facility, and they've analyzed the soil that's outside the window, and they found that it had a high concentration of antipsychotic material in that soil. And it wasn't like some psychiatrists we opened up didn't go plant it there. It was because of the fact that the patients are literally spitting those medications, hiding it in their mouths and spitting it out outside the window. And there's various reasons why. One is, yes, sometimes these medications have side effects. They're changing the state you feel in. You're feeling in that state that there's nothing wrong with you. So all these things have to be considered. Risk to self, risk to others, risk of compliance, and risk of absconsion. If these factors are in play, if you're concerned about the patient's safety or other safety, if the patient will be aggressive, you've got to make sure that the patient is in a facility that can accommodate them. This is very, very important. We're finding sometimes that in an effort to sometimes keep a patient in the facility, it can be to the detriment of the patient, to the staff, and to the other patients. So all these things are fundamental to the assessment of a patient who comes into the facility. If at times you find that the patient is well for a moment in time and then unwell, and you can't explain it, one has to be careful that the patient's not going through, again, like a medical state of what we call delirium, where the patient can be talking normally to you for a few minutes and then not be well for the next few minutes, where they're talking inappropriately. And there again, it's important to medically assess, make sure there's no underlying medical problem that's predisposing to the patient's presentation. Now, another factor to take into account, so we've covered the psychiatry illnesses and how they may impact on a patient in terms of their presentation. One of the factors that at Eden we faced lately, Tranquility, is the fact that we had patients coming through and they were assessed as being unwell by the staff appropriately. And then when they would come and sit with myself, and this is usually the case, as you'd get the doctor to come through urgently and the person presents quite normally and you wonder what happened. But very much so, we saw this in the last few patients we had, a few patients at Eden Tranquility, where they were basically what we'll say personality type disorders. So at times they would be aggressive, angry, shouting, and then they would be as calm as the ocean on a good day, where they'd be having an amazing conversation, helping us. And then when the patient would leave, I would get the feedback that doctor, he's been inappropriate, he was aggressive. And this is where, and this is very important again, if circumstances, situations, person, and people are influencing the patient's presentation, that's very important to take account. That means the patient, he or she will claim that they're not, but is able to control their presentation. So it's a particular circumstance, event, person, or people that's influencing their presentation. And if they're able to control it, that means it's very much within their power. And this is where you see it, especially in personality types. So, for example, an antisocial will appear, let's put it this way, let's give it an extreme example. Perchance the antisocial will have to appear in court. And in front of the judge, they will appear as the best person, the most righteous person. But outside, perchance, they want to do something that's quite nasty, they will be nasty. But perchance they in front of the judge, they will be, as we may say, as sober as the judge. So be wary that patients will present differently to different people. It is not an unnecessarily, we still need to investigate, an underlying psychiatric disorder, but it's bordering more on the personality type. And patients, and the problem many a time we face with personality types is that, as I mentioned, you get the deviant personality types, the antisocials, the borderline, the narcissistic. There's even talk in this day and age of what we'll call the psychopaths. They will appear in a way that suits them for that particular situation, person, and people. They will look at what's best for them. They will endeavor, and I'm going to use a strong word here, to manipulate the situation to suit them. So one has to be very careful of these type of patients because they can create havoc. One of the ways they do it is what we call splitting. So interestingly, over the years, we see this often where they will say one thing to one therapist and another to another, and they'll create chaos in, be it the rehab facility, the sober house, the halfway house. And this is where very strong structure is needed. This is where we stick to the rules of the game. And this is where ward rounds are necessary as well. So we share with each other the various ways that the patient may be presenting, and we come from a united perspective rather than from a separated perspective. And this is what patients, they'll say they don't do it deliberately, but this is so much part of their personality or psyche that they don't necessarily know how to act differently. In many ways, as they are creating chaos and sabotaging the program, they also sabotage their treatment. And their level of commitment to the program sometimes, as much as they claim it's high, can be for that moment in time. When they're out there, when they're back into the chaotic world that they live in, sometimes that's why, sadly, lots of them relapse, because they struggle with making that shift. But what we find as a result, over time, because of the chaos they create, they end up more and more in a negative space. And they even, we'll use the words, drop down socioeconomically. They come from a space where they see their lives as empty and scarce, and they literally create that emptiness and scarcity within their lives. So one has to be very wary of these personality types because they can create a lot of upheaval in various facilities and actually jeopardize other patients' treatment. So strong structure, discipline, sticking to the rules of the game are needed. And many a time, sometimes you'll find these are the patients that will RHT, refuse hospital treatment. They'll come and go from various facilities. No facility is good enough. It's always someone else's fault. It's basically what we'll call, they have an external locus of control. And an external locus of control is where we rely on the outside world to give us the affirmation, approval, appreciation that we want. They don't have internal nidus. They don't have an internal sense of themselves. And for all of us, we all need to have an internal sense of who we are so we can develop who we are in people. If we keep relying on the outside world, all it does is it fuels our ego. And as much as our ego is appreciated, acknowledged, at some point, all it's doing is facilitating a sense of emptiness within us. So, yes, personality types, one has to be very wary of them because they're a huge part of the practice, they're a huge part of substance use, and as far as we shifting the patient from a position of intoxication to sobriety, we're also endeavoring to shift them in terms of their personality. How are we trying to shift them in terms of their personality? Again, as I said, is moving them from looking for external affirmations to one that's within. So that is why many of us struggle when we give up substances. They'll tell you, if you ask a patient, what is it that you feel you'll struggle with on the outside? They will say, I'll have to, how do I describe to my friends now that I'm not using? And some of the realities that they have to face is that they will have to change their group of friends. Because unfortunately, the group of friends that they're using with, they're going to find when they're back in that social setting, they're going to be tempted to use. And if they're not tempted to use, they're going to get bored. So these are the challenges. So the patient, fundamentally even at a personality level, will have to come to terms with their various personality traits. We all have at some level some personality traits. We all may be at some level wanting to be a center of attention, wanting some level of affirmation and acknowledgement. And these, as we learn as we go through life, needs to be far and far more controlled. So yes, so personality in that sense, we will be part of a rehab program is helping the patient to see themselves for what they truly are, rather than what they make themselves out to be. So again, I repeat, to see themselves for what they truly are, rather than what they may make themselves out to be. Number two is to see themselves for who they truly are, rather than what people make themselves out to be. And this is where they struggle when they go out to be with this group of people who saw them as the party animal, who saw them as the one who was amazing when they used a couple of substances, whatever it is, they'll have to give up that, to see themselves exactly as they are rather than what people make themselves out to be. And I always add this third one, to see themselves as they truly are, rather than what the whole world may make themselves out to be. So again, they'll find themselves in settings, and it's easy to see if you go to any restaurant, if you go to any private social function, alcohol is always generally available. Substances are available somewhat illicitly, but alcohol generally seen as part of the social function. And they'll have to see themselves as who they are rather than what the world may make themselves out to be. And that's why the expression, lead us not into temptation, that means to not go there, rather avoid going there. And it's very important sometimes. Patients will have to learn these things, which I know Eden Tranquility teaches. You'll need to leave the function early if substances are being given out and whatever it is, in whatever form. So these are the changes as a patient has to make. And by default, what we're doing as well is endeavoring to, I'll use the word, shift their personality type. From being narcissistic, where it's all about self-ego, self-presentation, they will have to get to a place where it's about selflessness. It's about what you can give rather than what you can get. And I know the 12 steps cover these various points of shift. And their personalities, as much as they were the raging antisocial, they have to literally subdue it. And some would argue that it's difficult to change a personality type, but more and more, medicine even, given that we are very, maybe some would argue, a stagnant profession, sees the brain, the mind, as a dynamic entity, that it is possible to change it. In fact, in closing, let me maybe bring up what I'll use as the holistic treatment of a patient. And I know Dr. Steve is covering later about the biological aspect. So just in summary, some of the things is biologically, is yes, we give patients medication. It's important when the patient's psychotic that we use medication. If patients are so severely depressed, they cannot even focus on the program. Medication is necessary. So biological treatment is important. Exercise is important. Things like some would consider within the biological realm, meditation, all these things contribute. Your diet definitely is a huge part of your biological treatment. Whereas you rely on alcohol to help you sleep at night, and you'll have to recognize now that you can't be having, as some patients describe, 2 to 3 cups of coffee plus a Red Bull before you go to sleep. You have to cut down on the nicotine intake. So all these things, eat fresh vegetables and all these nice things. Make sure your protein intake is enough. So biological treatment is fundamental to the treatment. And biological is where we see the quickest shift in a patient. So that's why all of us want the quick fix, the biological treatment, as much as we may at times disapprove of it. So that's the one aspect. The second level is psychological. And I'll use the word mental. And this is where we bring about, let's use the word, a deeper logical and rational shift to who we are. And what do I mean by that? When we end up in a rehab facility, I'll use an expression that Einstein used. If you try to solve a problem at your original way of thinking, you end up at the problem. And he uses words like, you've got to expand your consciousness beyond the problem to find the solution. And this is from a man, Einstein, who didn't use any substances. He had a love for ice cream, apparently. But he describes expanding your consciousness to find a greater level of thinking. And this is what the 12 steps and the various facilities endeavor to provide. So that's the psychological, the mental, and shifting our thinking, not recognizing basic things like, doctor, I need to have a joint of marijuana because that helps me stay calm. But patients refuse to acknowledge that, yes, it may keep them calm for 5 seconds, 5 minutes, but it's the rest of that 23 hours and 55 minutes that they're struggling with, because as much as it calmed you for 5 minutes, it shoots your anxiety levels through the roof for the next 23 hours or so. So those are other aspects which one has to take into consideration. The other level, so we covered the biological, the psychological. The third level is social and emotional. And this is family and friends. So as much as we just communicate with, but these are people that you connect with. And various levels, we all feel that we're not connected enough, or we do not get the love that we want. But we've got to recognize that the emotional connection is not going to happen waiting for others to give it to us. It's not about how much you give. It's about how much you can, it's not about how much you get, it's about how much you can give. And yes, people say, I cannot give, my cup is depleted. But we got to tap into that infinite ocean of abundance that we have within us so we can give. So that we then become not net takers, we become net givers. So, yes, and that's where love, respect, dignity even comes in, humility, compassion, gratefulness, graciousness, gratitude, care. All these things are part of the emotional spectrum. And let's put it this way, if you feel truly, truly that you are loved and feel respect, self-respect, it's far less likely that you will end up using substances. So again, it's the biological, the mental, and then the emotional. And the fourth area, as much as we call it spiritual, it's about your calling and your purpose. And this is where it's about absolutely your giving, your legacy, your truth. As much as it's searching for infinity and eternity. It's also about being part of a collective, seeing yourself as part of the collective. And this is where you got to really believe and live up to that greater purpose and meaning in your life. And it's not people ask me in terms of the work I do, what's my purpose? If you got to ask that question, it's not about what is your purpose, it's about doing your work with purpose. Doing whatever you're doing with absolute commitment, absolute presence, and absolute oneness with what you do. So again, if you look at it, it's the physical, the mental, the emotional, and spiritual. And as much as the facilities will provide the physical, the biological, and the psychological, a huge part of our work is the emotional and the spiritual. So those are part of the spectrum of the holistic treatment. And as you get into the more emotional and spiritual, that will help. And the reason I introduced this was that will help more so with personality types. Where if you look at it, the first two is about what I can get in terms of the physical and the mental, what I get from people, but the emotional and spiritual is about what I can give to people. And this fundamentally shifts the way we are as people and allows us to heal. Because if patients are still feeling an emptiness within, if people are still feeling that they come from a space of scarcity and a lack, they're going to be always then demanding of others to give to them. And why is that also important, especially from a substance perspective, is if they're feeling empty, the lack, the scarcity, they will always look to a substance to numb them. A thing I will say, I'll ask patients is, why do they use? And one of the original reasons you'll find is when they first used it, it was an experiment. And then the experiment, as much as foul-tasting alcohol is, or marijuana made them cough, or whatever it is, from the experiment they find whatever it is that gives them a level of pleasure. So they use it for their pleasure zone. And as Katlego was describing, at some point though, they need more of that substance to give them more and more pleasure, or to give them that same level of pleasure. And what they're doing is basically artificially pushing their brains into a zone which gives them that pleasure. All right, the dopamine levels are shooting through the roof. Whatever it is, the serotonin levels are going higher and higher. So those are the reasons we use. But by the time 99% of patients come into a rehab facility, they're using the substance to numb the pain. And what they're finding is that the pleasure, the substances, as you take, even as more and more you take, you find that the returns are diminishing. You are not getting the level of pleasure you normally get. So at that level, you end up using it to diminish pain. And that's when patients, in the moments of pain, in fact, they have the pain a lot, but they use the substance more and more to diminish the pain. But then the amount of substance that they have to use, and they use the substance for more and more longer, the pain comes in those moments where you're not using it, or the effects have worn off. So the pain becomes more and more worse. So that's when they're more likely to come into a rehab, and that's when they're more likely to seek the help and be realistic about the help. What we find, though, interestingly enough, that the younger users, abusers, or those who use substances, possibly can be at a level of pleasure. And the reason is their brains, their minds are still growing organically. And the reason they come in, though, is because their parents or some family member or someone in society has brought them in out of concern. And they are coming in because hopefully they still give into authority and they're more prepared to listen to someone. But as we grow older, we're less likely to acknowledge we have a problem. In fact, we find that prior to coming in, that's the most difficult part with a person who's using substances, because they're less likely to acknowledge it. And if they internally, within themselves, acknowledge it, they won't want to acknowledge it to the outside world. They want to say, I've got it under control, I've got it sorted out, I'll sort it out myself. But by the time they come in, they're completely broken. And once they're in the facility and they're surrounded by other people in the clinic, then they recognize, I'm the average of everyone around me here, and there's some worse than me and some less so than me, and therefore I do fit in. So this is part of the substance users and their journey in terms of their personality type. So as much as we're treating them for substances, rehab facilities are also treating personality types. Some of them we don't even get to see in psychiatric practice. We're less likely to see an antisocial. He's not going to come in for treatment. But the rehab facilities are more likely to see them. And one has to be very wary of them because they can create havoc in the facility as well. Because once you're there, you're not exposed to your usual behavior. You're not able to express your usual behavior. You're not getting people manipulated. And you're going to try and test the system. So this is where it's also very important. Yeah, so in summary then, when a patient presents, we have to make sure that there's no underlying medical disorders, and this is where a doctor would come in and make sure, and if you feel that in some way, this is over time or experience as a layperson who hasn't had a medical background, you will pick up there's something different about this patient's presentation. And there also, we have to also make sure that there's no underlying psychiatric disorders. And then something that will impact once the patient's admitted, as much as you've ruled out the medical and the psychiatric, is to ensure that we're not dealing with a pure personality disorder. And what you find sometimes is that personality disorder, as much as they're coming for treatment, but they find that they're able to manipulate others around them, are less likely than to focus on the treatment program. They're more likely to focus on their manipulation and endeavor to get out of others what they want. And that actually can even divert the program or digress the program for the patient themselves, those around them, and even for it impacts negatively on the therapeutic staff because they then have to deal with all these crises that the patient's creating. And the more chance that the patient gets to create a crisis, the more they will, because they, at some level, don't comfortable in who they are and don't wish to change. So these are some of the factors that one has to look out for. And yes, eventually, if we look at the holistic treatment, biological, the psychological, the emotional, and the spiritual, all these impact on the patient at various levels. We do, for example, with personality disorders, use biological, we use medication. Not that that's the cure, but at some level, it may curb their impulsivity, curb their, some of them are more likely to have what we call attention deficit disorder in terms of focus and concentration. So we will give them the underlying medication to help them focus and concentrate. And that's the biological. Then we will give them the tools at the psychological level via counseling to deal with their impulsivity, to deal with their personality traits. And also, hopefully, shift them to the part of where they can give. That is the emotional and the spiritual.